Good morning, everyone. This is Rebekah Gardner. I'm the clinical lead for care transitions for the New England QIN-QIO. On behalf of QIN-QIO, as well as the Massachusetts HIN, we are delighted to welcome you to today's webinar entitled A Call to Action, Targeting Sepsis to Reduce Readmissions. We have a great panel of speakers to help us get there. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded, and the recording will be available on our website within a few business days. As you heard, the phone lines will be on mute while the speakers are talking, but we will unmute the lines after the third presentation to take questions. We'll give some instructions on how you can ask questions at that time. Although the lines will be muted during the presentations, we would still like you to actively participate during the session by using the chat function, which you can see on the right-hand side of your screen for most of you. My colleagues will be monitoring the chat window and responding to your comments in real time, so please don't be shy. We'd love to learn more about your efforts and how we might best support you going forward. So let's start using chat right now by seeing who's on the call. Using that chat window, you can type in your name and your role, your organization, and the state that you come from. So go ahead and test drive the chat function right now on your own computer. These are today's speakers. We'll be introducing each one just before their presentation. I'm going to start us off. I'm a senior medical scientist at the New England QIN-QIO. I'm an associate professor of medicine at Brown University and a practicing internist at Rhode Island Hospital, both in the inpatient and the outpatient setting. Here at the QIN-QIO, I provide clinical oversight for all the care transitions work that we do. Everyone on this call knows that readmissions matter. They matter to patients because they're so burdensome, and they matter to payers because they're seen as a marker for the quality of care transitions at a particular facility. Over the past several years, Medicare has had penalties to higher than expected readmission rates, and we can see the conditions for some medical diagnoses listed here, including heart attacks, heart failure, pneumonia, and COPD. There are other penalties for some surgical diagnoses as well that I'm sure that you're familiar with. These are all really important conditions, but many folks have wondered if another important diagnosis was missing from this list, one that might account for even more readmissions than the penalties that are currently being given. And I think, given that you're all on this call, you know that I'm talking about sepsis. There are hundreds of thousands of cases of sepsis admitted to U.S. hospitals every year, and the costs are phenomenal. Estimates are between $15 and $24 billion. The human toll that sepsis takes is pretty profound. Folks are much more likely to die while they're inpatient than other conditions. There's cognitive decline that occurs after an admission for sepsis. And we know that people suffer from mental health conditions like PTSD after being cared for sepsis in the intensive care unit. They have significant functional limitations after discharge and a pretty profound decrement in their quality of life. This table is from a research letter recently published by Mayer and colleagues in JAMA, and they looked at the proportion of readmissions after an index day for sepsis compared to index days for other conditions. They hypothesized that sepsis hospitalizations could lead to a higher proportion of readmissions than hospitalizations for conditions already included in the hospital readmission reduction program. So when they looked at hospital stays that ended up with an eventual readmission, 12% of those index admissions were index days for sepsis. And as you can see on this table, highlighted by the box, this is a higher proportion than the index days for heart attacks, heart failure, pneumonia, and COPD. I thought this was important to point out because, as you recognize, those are the diagnoses that are included in the payment reduction program. They also looked at the readmissions themselves, and they found that when patients came back to the hospital after they were initially admitted for sepsis,
exceptional service and quality care at all times.
It sounds like someone might have put on hold.
Someone has put us on hold. Let me try and remute the lines and see if that will help us, Rebekah.
Sure, no problem.
So hold on one sec. You might have to, actually, did it go away?
I think it went away. Great.
All right, well, let's keep going, and if I have to remute, I can.
Okay. This gave you a little extra time to really absorb the length of stay data that's sitting in front of you here. Because when they looked at the readmissions themselves, these authors found that when patients came back to the hospital after they were initially admitted for sepsis, their length of stay during that readmission was longer compared to readmissions following the other more commonly tracked conditions. And those readmissions cost a lot more. And this has been demonstrated in other studies as well. There was a study in California, for instance, where they looked at annual costs for readmissions after sepsis, and those were more than double those following heart failure, for example, and 3.5 times more expensive than those following acute MI. I make an important point about the methods of the study, and usually I don't delve into methods on a webinar like this, but I think we ought to spend just 30 seconds talking about this, because this is a study that folks have been quoting a lot, and we need to look at one key factor related to their findings. When they went and identified index hospital stays for sepsis, they looked for a sepsis diagnosis on any of the 10 discharge diagnosis fields. But when they identified their other conditions, like heart failure and pneumonia, they only looked at the primary discharge diagnosis field. So you can see why that would lead them to identify a lot more sepsis index stays among the readmissions, since they're looking at 10 fields, versus the other conditions where they're only looking at the primary field. That's an important limitation. They did a sensitivity analysis to try to address this limitation, and you can see that here in the third column. That uses a much tighter sepsis definition and allows the other conditions like heart failure and pneumonia to be pulled from any of those 10 discharge diagnosis fields. The results look pretty different and perhaps more in line with what we would have expected. But it doesn't at all change the fact that sepsis still accounts for a pretty high percentage of the readmissions, regardless of how you do the analysis. Higher than a lot of us probably would have expected. In the years following a severe sepsis admission, so when folks are admitted and then leave, for the folks who survive to discharge, 44% then die in the year following their admission, and most are readmitted. Just one study by Prescott found that 27% were readmitted within 30 days, 40% within 90 days, and almost 2/3 within a year. In fact, only 20% of sepsis survivors were alive and not readmitted in the year following the severe sepsis readmission. And similar numbers have been shown in other studies. Chang and his colleagues found that the readmission rates were also in the 20s, between 20 and 27%, which is, can be higher than certainly acute MI, and then certainly higher in some estimates than CHF or pneumonia. These folks also tend to have a lot of time in skilled care facilities after discharge. 1/3 go to skilled care facilities, and here I'm not just talking about SNFs, but I'm also talking about acute rehab and LTACs. These numbers don't include long-term care like nursing home custodial care. And they found that patients spend a median of 10% of their days alive after their discharge for that sepsis admission living in some sort of facility. And when they come back to the hospital, as it sounds like many inevitably do, they have worse outcomes of their readmissions. They're more likely to be put in the ICU, they're more likely to be transitioned to hospice, and they're more likely to die. What sort of diagnoses do patients with sepsis come back with? Well, the highest proportion actually come back with sepsis. Other common diagnoses they come back with are CHF, pneumonia, and renal failure, as you can see on the slide. Comparing this group to matched controls without sepsis, those who had sepsis for their index day were more likely to come back with sepsis, renal failure, and respiratory failure than non-sepsis patients. And these conditions are highlighted with the blue arrows here, where you can see the percentages. These same authors wondered if some of the readmissions might be preventable. They noted that many of the sepsis patients came back with another infection of some sort, 12% in fact, which was higher than for non-sepsis patients. And when they looked at those readmission diagnoses and they classified them as ambulatory care sensitive or not, they found a high proportion of readmissions that maybe could have been avoided if the conditions were discovered earlier or treated differently. Their estimate was fairly wide-ranging, from 22 to 42%, kind of depending on how they defined ambulatory care sensitive condition and what they included. And they also noted that any intervention would have to happen quickly because a lot of the readmissions were in the first couple weeks after discharge, which, as you know, is true for non-sepsis-related readmissions as well. Some researchers have looked at which patients with sepsis are more likely to come back. They did find that the severity of sepsis, as it was coded in claims, was not a predictor, actually. but younger age, having Medicaid, and certain comorbidities like malignancy were associated with higher risk. And different studies have conflicting findings about whether male gender or race have an impact. I'd like to turn now to some of our New England data as analyzed by health district advisors from Medicare claims. What you have here is a graph, and the red line at the top shows readmission rates following an index day for sepsis in New England. The readmission could be for any reason, but the index day had to be for sepsis. The blue line just below that shows readmissions following an index day for any condition. And the rates are trended over time, as you can see on the x-axis, from the end of 2013 up to the fall of 2016. And readmission rates for sepsis are higher than for other conditions throughout this period. And in New England, in the 6 New England states, they range between 20 and 21%. This is somewhat consistent with national data, although maybe a little lower than other estimates. We found in our care transitions work all along in New England that the northern New England states often have very different trends and outcomes than the southern New England states. This figure just shows readmissions after a sepsis day. So it's like we took that red line from the prior slide and broke it out into each of the different states. Each line represents a different state in New England. The southern states here are in dark colors, and the northern states are in light colors. And you can see that there's a difference in the rates. That ends up paralleling the difference in their overall readmission rates. So southern New England tends to have higher readmission rates for sepsis. And Massachusetts up there at the top, and Vermont is at the bottom, and this is at a time when you really want to be at the bottom. We also looked at what our sepsis patients come back with, and it's similar to national data. This table has combined New England data for our 6 states for 2016 and shows that the leading readmission diagnosis after sepsis are sepsis, heart failure, and pneumonia. I've included some ranges here because the proportions are slightly different depending on how we accounted for missing data, but it generally gives you a sense that the vast majority, well, I shouldn't say the majority, the highest proportion of any one diagnosis that folks come back with is sepsis, followed by kind of our common readmission diagnoses. When we look ahead to addressing some of these findings, and Maryanne and Matt are going to take us through some exciting work, it's important to keep in mind recent changes that's going to impact this work. New definitions for sepsis were recently released at the Society of Critical Care Medicine Conference and published in JAMA last year, and this is the first significant update since 2001. The new definition of sepsis is similar to how we would have defined severe sepsis before, and you can see that septic shock is somewhat similar to how it was defined earlier. There are some big changes. For example, there's no more severe sepsis, and we're no longer supposed to use SIRS criteria to define sepsis. What we would have called sepsis before, with an infection and 2 or more SIRS criteria, is now just thought of as sort of a routine infection with a normal inflammatory response. And we're supposed to use things like SOFA and lactate to define sepsis as opposed to SIRS. So despite the consensus among the professional societies about these definitions, they're not widely used yet, and the ICD-10 coding is not quite there, and Medicare is not quite there. Other important changes that are coming are in the form of penalties in the hospital readmissions reduction program. Sepsis is now included, but not as its own category. It's linked to pneumonia. So if the principal discharge diagnosis is sepsis and there is a secondary diagnosis of pneumonia on admission, that will count now in the pneumonia tally, and that's new. One exception to this is if you coded the sepsis as severe sepsis, which you'll remember from the previous slide no longer exists. So that gives you a sense of the challenges we're all going to face in this going forward. So how we define sepsis, how we code for it, how we're paid for it, and how we're penalized for it are all in flux. In spite of this, we are not afraid, we are not daunted, and Maryanne and Matt will now walk us through how we can make a difference in the outcomes of our patients with sepsis, no matter how we define it. I'd now like to introduce our next speaker. We are now going to hear from Maryanne Whitney, and she is an improvement advisor with Cynosure Health. She's the lead for subject areas of sepsis, delirium, and airway safety, and she joined Cynosure Health with over 25 years of hospital operations and nursing and leadership expertise. She has extensive experience in critical care, patient safety, sepsis mortality reduction, delirium, and rapid response teams. She earned her Bachelor of Science degree in nursing from San Jose State and her Master of Science degree in nursing and critical care. Maryanne, you should have the ball and be ready to go.
Maryanne, don't forget to unmute yourself by pressing #6.
Thank you, Rebekah. Sorry, I thought I had unmuted. Hi, thank you, Rebekah. I thought I had unmuted. Sorry about that. Technical difficulties. So I want to thank you again for having me, and I look forward to sharing this information with you. Please, if you have any questions, just chat them in the chat box, and happy to respond to those. So let's get started. We're going to talk about strategic sepsis care. And Rebekah did a nice job of summarizing the cost and the harm that occurs with sepsis. And one of the other things that recently came out with Society of Critical Care Medicine and Surviving Sepsis campaign is that sepsis is now recognized as a medical emergency, which is wonderful news. I think it'll give it the sense of urgency it needs in our hospitals, recognizing that it is the most costly reason for hospitalization. And more than 700 patients die daily from sepsis. That's one death every 2 minutes. So it is a significant health burden to our hospitals. This is the same table that Rebekah mentioned, and just wanted to remind us that readmissions due to sepsis are higher than the other ones that we get penalized for. And today we're going to talk about, detection, treatment, transition, and how do we survive sepsis or help our patients survive sepsis once they're discharged from our hospital. So early detection is key for all levels of our organization, so emergency departments, inpatient settings. I would encourage LTACs and our nursing homes to begin screening for sepsis on a daily basis. All of their patients. You can use early warning signs, the Muse score, things like that. They're maybe not going to tell you who has sepsis or septic shock, but they are going to tell you who's sick in your organization. And we want to treat all our elderly as high risk because they often have atypical signs of sepsis. They can often have an altered mental status, which we quickly attribute to other causes in the elderly, but often that is their organ dysfunction. And they can be afebrile because they have a tough time generating a fever. We also want to really make changes in our organizations to change culture to think sepsis first and believe it's an emergency. Often sepsis is the default. Once we go through the other time-sensitive diagnoses that come into emergency rooms, MI, stroke, trauma, those kind of things, then we get to sepsis rather than thinking of sepsis first. I think we all find ourselves going down that path. This is just a little pictorial that I like where you have 9 or 10 people resuscitating a patient, and then you have nobody in the room of the patient with sepsis in the bottom corner because it's often unrecognized. Some organizations have actually put visual reminders near patients to help the whole team understand that sepsis is an emergency. They'll put a different colored blanket on the bed or those kind of things.
Maryanne?
So once we...
Maryanne, this is Lorraine. There's a question in the chat about what score you mentioned.
Oh, the Muse score, which is an early warning score. Some facilities who have electronic health records have that automated in their system, and it's based on a multitude of patient indicators within the healthcare record, vital signs, level of consciousness, those kind of things. And if there's a big enough change in the Muse score, it sends an alert to the caregivers so that they can then either activate a rapid response team or understand that the patient is getting sicker, and it's MEWS. There's all sorts of alerts that can be set up in an electronic healthcare record or with sepsis screening in your facilities, you know, it can be on paper, and if the patient screens positive, we need to be doing something. The next step, once patients are identified, we need to have clear action for that early bundle implementation because it is a time-sensitive condition that needs to be treated early. And what helps with that is, you know, developing a team so that everybody's role is very clear about who does what by when. And this is a good place to build in a concurrent review so that you can really get a sense of timing for each of the elements of the bundle, and you can target where you need to work to improve. So one of the suggestions I have, and one of the things that a lot of facilities that have good success is they have alerts of some sort. Not just electronic alerts, or maybe not even electronic alerts, but resource alerts, you know, where they call a sepsis alert or a code sepsis overhead. And this really mobilizes resources. It gets the experts to the bedside that are needed. It allows for consensus and diagnosis amongst the caregivers. It helps everybody to understand that it's time sensitive. And when they're called overhead, it keeps that level of awareness about sepsis and septic shock ongoing in your facility. It doesn't lose its glamour. It also helps create action for somebody to give those antibiotics within the first hour, to get the lactate drawn, and to maybe start those fluids. And I urge you to think, can your rapid response team be involved? Can they be your sepsis champions throughout your organization? Because they are typically a mobile group of certain level of expertise. So once a patient screens positive for sepsis, and that can be, even though SIRS is not part of the sepsis definitions and sepsis rates moving forward, it doesn't mean we can't use them for screening patients to know if they're sick. And that's really what the systemic inflammatory response syndrome tells us, or the SIRS criteria tells us this patient is not well. So that on top of an infection can still be used as a screening tool despite having the SOFA and Q-SOFA triggers that can be used as well. But once a patient is identified as being sick with an infection, we need to measure that lactate. It shouldn't be something that we send out. It should be done locally and returned quickly. Getting blood cultures prior to giving antibiotics, and really one of the new recommendations, and it's not new, but it's now has a higher level of validity, is to give those broad spectrum antibiotics within the first hour of recognition, and then giving fluid for hypotension or elevated lactate. And then if a patient does screen positive or has septic shock, which would be those patients who have hypotension or a lactate, an elevated lactate, you want to give vasopressors to maintain a blood pressure map of greater than 65. You want to reassess volume size and tissue perfusion, and using dynamic processes, passive light rays, things like that, no longer need to have a central line. And you want to continue to remeasure the lactate because that's a good indicator of resuscitation endpoints and that the treatment is making a difference for the patient. So once you've done all this fabulous treatment in your hospitals, you then need to transition patients from multiple levels of care. It can be an emergency room to a critical care unit. It can be an emergency room to a med-surg unit if they don't have septic shock. It can be a critical access hospital or a rural facility to a larger regional facility. It can be when we're transitioning them out of the hospital to home, hospital to nursing home. And we really need to think about what we need to communicate about that sepsis presentation and treatment that we've accomplished, what the ongoing risk factors are for this patient, along the sepsis continuum, what's been accomplished, what treatments have been done, what the time frame is, and then try to begin to anticipate what could be what can happen for this patient downstream. This is an example of a handoff tool from one of our facilities in our HIN. And again, this can be used electronically. It can be set up as an Excel spreadsheet where you put in time zero and it calculates the rest of the times for you, or you just plug in the time that the key elements of the bundles have been accomplished. So let's think about complications and sepsis that really put our patients at risk for return to our hospitals, as this is focusing on readmissions. Acute kidney injury is a large complication, or I should say affects a large portion of the patients who come into our hospitals with sepsis and septic shock. So we really need to keep an eye on that. Do we need to be checking labs more readily when they are discharged? Do we need to maybe reevaluate the medications they're on if they're cleared by the kidneys to know that maybe there will be an excess of medication or those kind of things. And then keep an eye on those patients that were in the ICU, because they really do have a significant risk of the PICS, which is the post-intensive care syndrome. 50% of the patients with sepsis in the ICU end up with weakness and balance going home. They have thinking and memory issues in their cognitive realm, and they often will have PTSD, creating issues for their mental health. Also, we need to keep an eye on healthcare-associated infections as our patients transition out, and the antibiotics they're on. Do we need to reevaluate those before they go home? I had a personal encounter not too long ago with a friend of my father who was in the hospital with pneumonia on antibiotics, came home, developed severe diarrhea, and was readmitted within a week with C. diff infection and passed away. So these things are real in our communities no matter where we are, and we need to be alert to them. And how do we teach our patients differently before they go home to be alert to the signs and symptoms of infection? There are a couple of new ideas or new studies that have been released. Both of these are Australian studies, and the first one compared usual care to early physical therapy. And we know that early mobility in the ICU also has great effects for our patients, decreasing delirium, decreasing length of stay. And this study really reinforced that. They had positive effects on quality of life. They had a trend towards reduced hospital anxiety. Unfortunately, this first study by Hayambu did not look at readmissions or the cost of this shortened length of stay. The other study that was released is by Paras. They kind of work together, these two scientists, and they are looking at a post-discharge kind of multidisciplinary outpatient clinic to really screen patients and have targeted interventions for them. They're looking at the quality of life, readmissions, and overall healthcare use for the patients that are discharged with sepsis. There's no data yet. That study is still in progress, but it's really something to look forward to and look towards as we look to decreasing readmissions related to sepsis. These are some resources for you, and I just, again, want to thank you for having me participate in this.
Great.
Thank you, Rebekah.
Maryanne, this is Lorraine. There were questions in the chat that I was hoping that maybe you could address.
Lorraine, would you mind posting those? And let's just keep track of those, hear from Matt, and then I'm hoping that we can open it up so all the panelists can answer those at the end. Is that okay with you?
Oh, great.
So please keep track of those, because I'm watching the chat, and there's a lot of good stuff going on in there. I want to make sure we get to that, too. So, Maryanne, thank you very much. I'd now like to introduce Matt Schreiber. I'm hoping, Maryanne, you might advance one slide and then pass the presenter ball to Matt so he has control. While she's doing that, I will tell you that Dr. Schreiber is Vice President of Hospital Group Quality and System Safety for Spectrum Health That's a not-for-profit integrated health system based in Western Michigan, go blue. He is an experienced physician leader who is known for designing and implementing large-scale, complex clinical improvement strategies in quality and safety. And at Spectrum Health, he's responsible for creating scalable quality and safety infrastructure to meet the ever-growing needs of the health system, especially as healthcare reform continues to evolve. So I have a feeling he's going to be very busy over the next 6 to 12 months. He began his career actually as a rural primary care doc, seeing kids and adults in both the ambulatory and inpatient settings. And then in 2004, he focused his career on the inpatient setting and became an adult hospitalist, and then was promoted to lead hospitalist. And it looks like he's kept on climbing ever since then. So we are delighted to have him here and presenting. As soon as Maryanne passes the presenter control to him, we will have him get started. Maryanne, to do that, you just, looks like you figured it out. Thanks, everyone.
All right. Good morning, and thank you to the QIO for the invitation. I never turn down an opportunity to talk to a whole bunch of people who have no choice but to listen, because that's not really something I get in my private life, so it's really important that I capture those opportunities in my professional life. I wanted to let you know that I don't have any relationships to disclose with industry or research partners. In fact, I'm not even sure I have a relationship with my own retirement account anymore. My job is to present to you some of the information that we know about reducing hospital readmissions in general. I think you've already heard a very compelling argument about the special case of patients with a diagnosis of sepsis, but the essential truth is that routine hospital care is inadequate. The process that we use generally does not work, and that is irrespective of really the index diagnosis itself. And so a lot of the things that I'm going to talk about today apply generally across all diagnoses because they're really process issues that your organization may need to look at. If anyone suffers from insomnia or has a burning urge to understand everything there is to know about the Readmissions Penalty Program, I've given you a link here where you can essentially review the direct feed from CMS in all of its glory. What I would like to say on behalf of readmissions work is that really the public and our payers see preventable hospital readmissions as defective care. And I think we can all recognize that we do have a bit of a safety crisis in healthcare, where we know that these defects in care have significant impacts to our patients, and there's an ever-increasing public awareness about this. In 1999, the Institute of Medicine released its landmark report that said somewhere between 44,000 and 98,000 people lose their lives every year due to preventable medical error. We now know that the number is probably somewhere in the neighborhood of 200,000 people a year and potentially as high as 500,000 people a year. What you may not know is that if the CDC were to track deaths due to preventable medical error among its most common killers, it would come in somewhere between third and sixth, and ahead of other things that we think of as common killers. All of this is to say that there is great interest in readmissions because of its cost and its quality implications. Those implications are increasingly visible to the public, and so not only are we going to need to improve the activity that we do, but we're going to have to do it under the hot white light of public scrutiny. So in the end, what is it that we need to do in order to reduce hospital readmissions across all diagnoses? Well, it sounds deceptively simple. All we need to do is to make sure that the hospital staff, the patient, and this is really important, not just the patient, but the patient's main person who is responsible for their success. In my case, that would be my spouse. In other people's cases, it may be their daughter or their neighbor. But all of those people have to know the following information: the key diagnosis, the key tests and treatments that were performed during their hospitalization, the ongoing treatment plan, including what medications and what follow-up appointments they need, the red flag symptoms or the common side effects or failure points associated with that treatment plan, and they have to know who and how to contact someone if something isn't going according to plan so that the plan can be adjusted. The problem with discharges today is essentially they are often unplanned. There is ever-increasing pressure on reducing the length of stay for patients, which means it's not at all uncommon for us to wake up one morning and realize, oops, the patient is now ready for discharge, so we'd like them to get out of the hospital before 11 o'clock. Meanwhile, that information may have come as a surprise to the patients and their families, and so it can be difficult to operationalize a discharge. Because patients need to be sicker than they ever have been in order to even get into the hospital these days, the truth is that at the time of discharge, patients are not necessarily well. They're really well enough to continue their convalescence as an outpatient. This translates to having a lot of details still under activity or potentially dangling at the time of discharge. And because our system has become more fragmented in terms of responsibility and who's responsible in the inpatient environment and in the outpatient environment, and those are very frequently very different teams of people, it sets up the opportunity to have incomplete communication and a lot of those details really not being known or adequately covered by the person who actually needs to know them. So the net consequence of all of this complexity and fractionalization of responsibility is that unsafe discharges are an under-recognized and significant issue that really hasn't gotten a lot of concerted attention until the penalty programs were introduced. One of the challenges we have in healthcare is when we decide to work on something, generally speaking, we do a pretty good job with it. But we spend a lot of our time trying to evaluate, geez, I wonder what problem it is we are going to try and solve. And then we spend the next biggest increment of our time in how we define a dashboard that will tell us whether we've been successful. We spend a small amount of time actually implementing behavior change and, most importantly, ensuring that that behavior change is still being implemented in the way we intended weeks or months later. And then we spend another increment of our time trying to explain why the data that we collected doesn't really tell the full picture of what we were studying because the data doesn't reveal what we had anticipated in seeing. As it pertains to hospital readmissions, I don't want you to spend a whole bunch of your time trying to figure out what you need to work on. Here's the list. The top 10 evidence-based interventions that if you do them, they will work. So you just need to focus on which thing are we going to try to tackle and how do we see it through to completion, and to focus most of your time and energy not on what are we going to do, but how do we actually do it and how do we ensure that our organization continues to do it. In order to help you, I don't want you to spend a whole bunch of time surfing the internet trying to figure out what evidence exists. Here are 5 evidence-based change packages that you can use. If you look them up on the internet, you will find more information than you can shake a stick at. The issue about these change packages is it's hard to know that if you take a few elements from each of them, how it will all play out together. Each one of these change packages was tested as a bundle unto themselves. So if you only do 4 out of the 5 things suggested, it's not clear from the evidence how that will pan out for you. But if you were to look up all of these different change packages, you would see an awful lot of similarities in the essential problems that they are trying to approach. There's a whole bunch of information out there. You don't need to spend a whole lot of your time developing new forms and tools for your organization to use. Here's a listing where you can get all that kind of information downloaded for free for your organization, so you can do the minor tinkering that you need to do in order to make it functional within your organization. If you wanted to make the greatest impact by choosing only one thing to focus on in hospital readmissions, that one thing should clearly be issues surrounding medication reconciliation. There is a ton of information out there that says that issues surrounding medications and making sure that the medications are correct will have the biggest impact, bar none, of all of the interventions on that hit list. With that said, medication reconciliation is not an entry-level improvement project. It's a big monster that takes a fair degree of sophistication and understanding. So if you think your organization isn't quite ready to tackle that one, you can make at least some headway in reducing hospital readmissions with the other tactics that are a little more digestible, a little easier to execute, such as making sure that you have hospital follow-up appointments before the patient actually leaves the hospital. This is just a nice graphic that sort of helps people understand the impact and the implications and the challenges we have around getting medications. If you presume that patients leave the hospital with exactly the right prescriptions that they ought to have, so that's that first column that says this is all the medicines that the treating physicians wanted their patients to take, there's a voltage drop of how many of those prescriptions actually make it to the pharmacy. There's another voltage drop, and when you look at of the medications that made it to the pharmacy, how many of them actually get picked up. Another significant voltage drop when you look at of all the medications that were picked up from the pharmacy, how many of them were taken as the physicians actually intended them. And then another voltage drop down to, if you look at all the medications that were actually picked up or taken by patients and actually get to their first refill, you see that only a small proportion make it all the way through. I just wanted to take a couple of minutes to talk about the special case of sepsis and the experience that our organization had as we tried to tackle sepsis. At the facility that I worked with in Atlanta for about 10 years, we had a very successful sepsis collaborative where we reduced whole house mortality by 30% across the system. And we had a very useful social experiment in that when we backed away from some of the interventions that we had done, we saw our whole house mortality creep back up to its native rate, and when we re-implemented those improvement projects, we saw our mortality again decline by about 30%. So I feel pretty good that we could see that the things that we implemented made a significant difference, and that when we stopped doing them, we lost that improvement benefit. The first thing that I would say about sepsis is that treating people aggressively, particularly with fluids in the early minutes and hours, makes a huge difference. And I would say the majority of our mortality benefit probably accrued to diagnoses that were not sepsis. Said another way, we had to argue for a long time to get our emergency room physicians and our inpatient physicians to understand that fluids could be very beneficial for people. And we'd often have the discussion of, oh, do you really want me to treat every 18-year-old during flu season that comes into the emergency department with 2 liters of normal saline? And the answer is yes, that when young, otherwise healthy people come in and they're febrile and tachycardic, if you treat them with fluids, they get better. And many of them do have the flu, and they were never in the cards to go down the sepsis pathway, but actually they get better faster, have shorter length of stays, and can be discharged to the community at a much higher rate than if you never gave them fluids in the first place. So I just want to reinforce that sort of counterintuitive to all of the focus on sepsis is that when you give aggressive fluids in particular early on, you actually help a whole lot of people with a whole bunch of diagnoses, not just with your sepsis diagnosis. The second thing that I will tell you is that use of a sepsis order set and protocol, irrespective of what's on your order set or protocol, confers benefits to the population. But it's really important that the protocol be implemented at the earliest point in time that patients can be identified, and frequently in the emergency room setting, that is prior to the initial visit with the physician themselves. Said another way is we wanted to empower our sepsis protocol to be triggered by our automated prompts and by nursing assessments, such that patients were already receiving their fluids before the emergency room physician even made first contact with the patient. By doing this, we set the default in the right direction so that people were getting aggressive fluids, and if the physicians felt like that was inappropriate, they had to take them off of the protocol instead of forcing the physicians to recognize sepsis and then initiate a protocol. I would say that use of our rapid response team in responding to sepsis, no matter where it occurred, be it in the emergency department or in our ICUs, was very, very useful because treating patients aggressively for sepsis is very nursing intense. And so to have somebody, an additional pair of hands at the bedside, as well as a specially trained unit who understands the implications of sepsis, was very, very useful for us. We found that by focusing on the emergency department first, we were able to make enormous headway on treating sepsis in general in our facility. But once we had really refined our protocol and our program in the emergency department, we found that a lot of the risk assessment tools that we used in the emergency department could not effectively be used in the inpatient environment, in the surgical population, or in the ICU population, because essentially everyone who was an inpatient flagged positively on the tool. The tool was too sensitive for the inpatient environment for it to be useful. So we had to develop a separate risk assessment tool that was a little less sensitive and more specific in the inpatient environment in order for automated alerting to really be a useful part of our paradigm. I would also say that not only is the follow-up lactate in 6 hours really important as a marker to tell you, are you headed in the right direction, but we found a lot of recurrence in the inpatient environment of sepsis. That is, we got really good at giving people their initial bolus, and they responded well to that, but we didn't do a very good job at making sure that people continued to get generous fluids over the first 24-hour period, such that they were getting somewhere between 60 and 80 milliliters per kilogram over 24 hours. When we stopped giving people fluids aggressively, we saw that they had a recurrence of their septic state and a subsequent decline. So using a follow-up lactate level in 24 hours to help you identify those patients that were backsliding, I think can be a very useful tool. The last thing that I'll say is that sepsis is a very time-sensitive condition. such that doing aggressive fluids and antibiotic treatments just don't have the same yield outside the 1-hour window. And it is also true that the mortality benefit to giving fluids and antibiotics actually accrues minute by minute, such that giving it in 30 minutes makes a bigger impact than giving it in 60 minutes. So there's a clear stepwise decline in the benefit after 60 minutes. The point here is that you really want to push the system to get antibiotics and fluids in as early as possible, certainly within 60 minutes, but the sooner the better. So with that concludes the information I wanted to share with you. I'm going to pass the ball back to Rebekah and allow her to facilitate the question and answers.
Thank you so much, Matt. That was a really helpful and interesting presentation. I'm going to very briefly summarize some key points because I want to move on and spend the rest of our time having our panelists answer questions. We saw from our data that sepsis is a top diagnosis for readmissions nationally, as well as what we can see in our New England data. We know that the approach to sepsis remains systematic early detection and treatment, which improves survival, as outlined so nicely by Maryanne and Matt. We also know, unfortunately, there's currently no evidence-based interventions to help folks once they leave the hospital after a sepsis diagnosis. We don't have any interventions yet outside of our standard interventions that Matt covered so nicely to prevent folks from coming back in. So nothing tailored specifically to sepsis. So we're going to go to sort of a universal precautions model that he described where we can use the current evidence-based interventions. And we're going to recommend that folks just implement good care transitions best practices and focus on good sepsis care, as our speakers outlined. We bet that a lot of y'all are probably working on sepsis specifically and probably have some interesting data. So we want to make sure that folks do share what works if your facility or your organization or area is working on sepsis specifically. Now we get to the fun part of the morning. We'd like to spend our remaining time taking your questions. We have a lot of questions on the chat, so just to get right to the questions and not spend any more time, I'm actually going to keep the lines muted and just take questions off chat so we can try to get through as many questions as possible. So on that note, we have the first question that came through chat earlier during Maryanne's presentation is one of the participants noted that that there were many different screening tools available, and how do facilities choose among them, and should they use more than one? What could be the role of using more than one, and what she would recommend that way? So Maryanne, I'm going to direct that question to you.
Great, thank you. I think this was from Chris Mitchell. And, you know, whatever you use to screen for sepsis, it can be Muse, it can be SIRS, it can be SILFA, Q-SILFA, those kind of things. The underlying question in the sepsis realm is, does the patient have an infection? All of those screening tools will tell you about patients who are sick, and it's, you know, and they need attention, so we need to pay attention to that. I would suggest that in the Muse, you also have the SIRS built in there. So, again, it's sort of an organizational choice what you use, and I would also suggest that using the Q-SILFA can help you predict. That's a really good predictive, easy-to-use assessment tool that can tell you if the patient is likely to have a bad outcome. So maybe paying attention to bed placement for those patients, making sure they get in the ICU so they can get full treatment rather than staying out on the med-surg units where they may not have that ability. So that's kind of my message is whatever you use, if it's in the presence of infection, that's the key for sepsis. I hope that helps.
Thanks, Maryanne. Another great question from the chat was whether or not antibiotic stewardship programs, which are kind of occurring concomitantly, might be impacting the treatment of sepsis because maybe folks are hitting barriers to timely initiation of antibiotics, and I want to direct that question to Matt.
Yeah, there's definitely an interesting dynamic that's happening between trying to promote aggressive sepsis recognition treatment with broad-spectrum antibiotics, at least until culture result information is available, and antibiotic stewardship efforts and C. difficile infection rates and efforts to reduce C. diff, because obviously the more you use broad-spectrum antibiotics, the worse your antibiotic stewardship is, the worse your C. difficile rates become. For me, I think there's a very practical aha in the antibiotic stewardship experience of my facility, which is a lot of programs focus on the initiation moment of antibiotics. How do we restrict access to carbapenems and similar broad-spectrum antibiotics to ensure better utilization? But most of the excess use of antibiotics really is in the length of treatment. So in your facility, how long are people treating patients with pneumonia with IV antibiotics? If it's longer than 5 days, probably in most cases anything more than 5 days is too much. And how often are we forgetting to narrow the spectrum of our antibiotic use when better information becomes available through cultures or through ID consultation, etc. So I do think it is possible to hit the sweet spot of being aggressive with diagnosing sepsis early and treating with broad-spectrum antibiotics, but you have to, on the flip side, be equally as aggressive at narrowing the spectrum based on what kind of source you have. Is it a skin infection? Is it a belly infection? As well as ensuring that you get your blood cultures before antibiotic administration and responding to those blood cultures when you have that information. And then finally, by looking with a very critical eye on when is enough enough? What is the duration of treatment and the variability of that treatment when we are treating patients?
Thanks, Matt. The next question was about whether or not CMS is supporting or endorsing these new sepsis definitions that we went over anytime soon. I can take that one. The answer to that is no, they're not. They actually published a letter in JAMA a couple months after the new sepsis definitions were published saying that they were not going to change their IQR, their inpatient quality measures that were implemented the prior year, and they said that, what, these definitions, the old definitions were very well understood. People like CERS, it's practical, they've been field tested, and while, they're open to folks doing some innovative thinking and pushing boundaries until there's good clinical trial data to support those new definitions, they're sticking with the old ones. So on that note, someone else asked whether or not SNPs should be ordering lactate, for example, to evaluate evaluate for sepsis. So, Maryanne, why don't I give that one to you? And if you wanted to address how we can engage post-acute care providers in general, that might be helpful too.
Right. Yeah, so I think in SNPs and any post-discharge healthcare setting, I really think things like the QSOFA are going to come of age because it doesn't include a lab draw, and it's level of consciousness, respiratory rate, and blood pressure. So if you get two or more positives out of the QSOFA, that the patient is sick, and in the presence of a new or suspected infection, that would be a time to call out for some help, some assistance from another facility, those kind of things. I think SERS can also be used, but I think screening in a subacute setting or an LTAC is probably one of the next steps we need to take so that we capture the patients early and they can come back to the emergency department sooner, even though we're trying to avoid readmissions, but really that early treatment is going to be key for them.
Thank you, Maryanne. There are a lot more questions in the chat, and so unfortunately, since we're at the top of the hour, we are not going to answer those right now live, but we will try to answer all the chat questions and make those answers available so that if folks didn't have their questions answered or were intrigued by a question that was asked, they can get the answer to that question as well. I apologize for not being able to get to everyone's questions this morning. So with that, I'm going to turn it over to Morgan, who's going to wrap things up for us with a little more housekeeping and some information about upcoming programs.
Hey everyone, this is Morgan. As you can see on the screen now, these are a list of upcoming webinars that we will be having between now and the end of the month, so be on the lookout for information about those. Let's see. And as you can see here, the New England QIN-QIO is now on social media, so be sure to go on Facebook, LinkedIn, and YouTube and like the New England QIN-QIO. As you close out of the webinar today, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill it out right now or sharing your computer with someone, you will receive an email tomorrow with the link to the evaluation as well as the link to the event page on our website. As Rebekah mentioned, we will try and answer all of the questions that were placed in chat and hopefully get those out in the email tomorrow. Within the next few business days, the recording and transcripts will also be added to the website. Again, be on the lookout for information about our upcoming webinars, and thank you to all of our speakers, and have a great afternoon.
The leader has disconnected. The conference will be terminated in 5 minutes.